a 64-year-old man, fatigue, mild jaundice, pallor and mild scleral icterus, low hemoglobin, high total bilirubin, high LDH, low haptoglobin, negative Coombs test, low reticulocyte count. Which of the following is the most likely diagnosis? This one is actually not easy and may be tricky. The diagnosis is common and comes many times in obvious vignettes, but this one is not. It's clear that the patient has anemia, but no MCV mentioned, or the other clues that were used too. Also, we see high total bilirubin, high LDH, low haptoglobin. We say, well, it might be a type of intravascular hemolysis. But then we see the Coombs test and it's negative. So it's not A. We mentioned many times before, warm autoimmune hemolytic anemia comes with a triad of splenomegaly, hemolytic anemia, and jaundice, and looks like hereditary spherocytosis. Also a Coombs test that should be positive. None exists here, so it's not A. Also nothing mentioned about thrombosis or any other type of cytopenia like thrombocytopenia or leukopenia, so we may exclude B as well. PNH has that triad of negative Coombs, hemolytic anemia, and venous thrombosis, especially Budd-Chiari syndrome. Nothing here exists. I mean, we have a negative Coombs and a hemolytic anemia, but no venous thrombosis. Also, there is another clue that I'm gonna mention later. Then we have G6PD. Also, nothing mentioned about back pain or dark urine, or that he took some medication or had an infection that led to that hemolysis, so we can exclude this G6PD deficiency. Then we have TTP, hemolytic anemia, thrombocytopenia, renal failure, fever, or neurologic manifestations, chest sites. Nothing mentioned except that there is a hemolytic anemia. But something to know about TTP is that it's treated with plasma exchange. That's very, very important. So all that might lead to choice E, vitamin B12 deficiency. As we have a very, very important clue and the only one that led to that correct answer, it's the reticulocyte count. We previously put in mind that the diagnosis could be a type of hemolytic anemia based on the LDH, total bilirubin, and the low haptoglobin. But if it was hemolytic anemia, the reticulocyte count should have been high, not low, because the bone marrow should have worked harder to compensate for the lyzed RBCs, and that is not the case here. Actually, the low reticulocyte count proves that there is some problem with the RBC synthesis, and that might as well lead us to exclude choice A and B and C, because normally vitamin B12 is required for formation of thymidylate and purine molecules for DNA synthesis, and B12 deficiency leads to ineffective erythropoiesis due to delayed nuclear maturation, and that leads to formation of megaloblasts and the things you know. All I want to remind you with here is that in vitamin B12 deficiency, you have a low reticulocyte count. And that's unusual vitamin B12 deficiency question, because here the vignette didn't give, as we said, the MCV, which is always high. It's easy to know it's vitamin B12 deficiency once we see it, because when we see it more than 100, we say, well, it's vitamin B12 deficiency or folate deficiency. But now it's not mentioned. Also, nothing mentioned about hypersegmented neutrophils, homocysteine, or methylmalonic acid, or that the patient is vegan or alcoholic. So we should know that vitamin B12 deficiency also causes a type of hemolysis. Unlike the normocytic anemia, it's intramedullary, so increases the LDH and causes indirect hyperbilirubinemia too. And here are our side notes, which I recommend you to read.